afternoon, everyone. Thank you for joining us this afternoon. My name is Trisha Riley, for those of you who I've not met yet. I appreciate your coming today if you're here in person or if you're streaming live. Thank you for coming with your questions. We have the Healthcare Matters program that we're starting February 1st, and there were some questions that arose. So we have Cigna representatives here to address your questions and concerns. And I'll hand it over.
Thank you, Tricia. I'm Andrew Belmere. I'm the Senior Account Manager for the Washington County Public Schools account with Cigna. My idea today was we do a question and answer session to make sure that we're addressing any concerns about the rollout, make sure there's a lot of clarity around how this is going to work and look and feel. And I brought a lot of people with me here today. The star of the show will be Sarah Williams here, who's our client service executive that we had local that we could drive in here to kind of get deep in the weeds on some questions. Now, I will say, though, if we're dealing with individual situations, this is a product that, you know, when you think about specific situations, we're going to need to take those to the side because every situation is going to be different. So it's going to be more high level on how it will work. So like a theoretical conversation as opposed to I have X, Y, and Z going on because the diagnosis could be different for each individual and how we're going to review it. And then we also have Chris Jones here as well, Client Engagement Manager, who will help as we roll this out, communication items that come through with this. And Jesse, who was in that role before, who is here just to help support as well as we do the baton passing back and forth here. And she's also going to run the mics today, so it's very nice of her to do that. So with no further ado, I'll pass it over to Sarah, and she's going to start handling the questions in the crowd. Thank you.
Hi, everybody. As Andrew said, my name is Sarah Williams. My role is a client service executive. So what that means is I'm an extension of your HR team. If there's a question, if there's a communication, anything like that that's needed, the HR team can reach out to me and I can help with those things. So I welcome any and all questions that you have. Feel free, you know, if I'm talking through something and you want to take some notes and ask a follow-up question, please feel free to do so. So with that, I'll open it up.
Okay. I have an online question, and again, for those who are streaming, please feel free to access the Google Docs or email me directly if you have my email, and ask questions as we go. I'll read your questions and not identify you. This question came from an employee. It says, and this is something that I think most people are concerned about, so it's a great one to start with. I'd like to understand how it is considered better care when someone is denying a service that my primary care physician, who has my entire medical history and who has physically seen me, how that person, her doctor says that it's necessary for appropriate next steps, how Cigna is denying that. My concern is that something may get missed until symptoms have increased and often with serious medical concerns. It's best to identify them early and treat them early.
Yeah, I think it's an excellent question, and I'm sure it's one that's on everybody's mind. As soon as you hear the term pre-certification, or you hear the term approval, my health plan has to approve the service. We are in no way, shape, or form looking to question your doctor. So I'm going to put that out there first and foremost. What we're looking to do is make sure that you're getting the appropriate level of care in the appropriate place for that care within the appropriate time frame. So the process that's going in place right now for you is really not that much different than what you've had in the past. In the past, you've had inpatient pre-cert. Are you guys familiar with that? You've heard of that in the past when you've talked through your benefits. So if you're going inpatient, if you're going to a hospital, you're going to have a surgery, something like that, that's going to be pre-certified. And from kind of the nods and everything that I'm seeing in the room, it's a process that's intended to be seamless. And it seems like it has been, which is a really good thing. It's a process that happens between your doctor and with Cigna, and 9 times out of 10, you don't know that it's happening. So that's a positive, that nobody in here is really aware that that's something that happens. So what's happening as of 2/1, we're just expanding that program to include some outpatient procedures too. So let me put your mind at ease right away with that. Your office visits, your colonoscopies, your mammograms, anything like that that's done in an outpatient setting, those things are not going to require a pre-cert, okay? So just take that off the table right there. This is not going to be a situation where every time you want to go to the doctor, you have to get a pre-certification. That's not what this is meant to do. Does that help to answer the question? Okay.
You mentioned mammograms. Does that include a 3D mammogram?
That does include a 3D mammogram.
Thank you.
Yes. Hold on. Oh, we need the microphone so everybody at home can hear us.
I have a question about who's responsible for getting pre-certification, because I think it's new that we're responsible now for getting pre-certification, and what's the procedure?
Right. Excellent question. So if you're utilizing an in-network provider, which the majority of people do, you're using in-network providers, it is not your responsibility to get the pre-cert. How the process works is when you're going to have an outpatient procedure, your doctor's office, without you ever knowing about it, will contact Cigna, and they'll verify your benefits. When they do that, they're going to have something called a CPT code. Has anybody in the room ever heard of a CPT code? I know Tanya has. Anybody else ever heard of that? It's a specific code that doctors and hospitals, all kinds of medical providers use to identify the type of service that you're having. So the doctor's office will call Cigna. They'll say, this is what we're looking to do. Can you verify the benefits for us? At that time, our customer service team is going to say, it requires a pre-cert. And the in-network provider is going to start that process without you even knowing about it. Okay, from there, it's either going to get approved or denied through the medical necessity process. So I'm sure that begs the question with somebody who decides whether or not this is medically necessary. Cigna is using industry standard information, so it's something that you're going to see from Cigna, from Aetna, from United, from Blue Cross and Blue Shield, you name it, across the board, all the carriers are using this information. It's been developed by doctors, pharmacists, nurses, all kinds of medical professionals. It's board reviewed. Sometimes there's peer review or there's published literature that's being used, and there's something that Cigna calls a coverage policy. The coverage policy documents are public. You can go out on Cigna.com and find them if you ever had a question or were so inclined in your free time to want to go out and take a look at those. But what we do is we review against this industry standard that's out there for care. If everything is in line, the care is appropriate, it's medically necessary, that approval is going to go into place, and you're never going to know. You're going to have your service, and everything is going to go through. I think the question that you have comes a little bit from what happens if I go out of network. Okay, because if you're looking at the flyers that were handed out when it says, who's going to request this for me, if you're using an out-of-network provider, ultimately, it does become your responsibility to start the process. And I know a lot of people hear that and they think, I'm not a doctor. I don't know how to start this process. I don't have CPT codes. I don't have access to this information. What you're going to do at that time, contact Cigna. They're going to tell you yes or no, this does or does not require a pre-certification. You're going to give them your information, and in the majority of cases, Cigna is going to reach out to your provider on your behalf. They're going to say, we're looking for this information. Can you send it to us? I've been doing this for 16 years now. I have really yet to encounter even an out-of-network provider who's not going to cooperate and give you what you need to get your pre-cert. They want you to have the care the same as we want you to have the care, so they're going to usually cooperate and give you the information that you need to be able to submit that. Another excellent question. So you're going to want all of your information, so your name, your ID number, date of birth, address, all of that. And what's going to be most important for you at the out-of-network level is something called a letter of medical necessity, okay? It's something that's very familiar to your doctor's office. Once you ask for it or you say that you need it, they're going to know exactly what it is that you need. So we're going to look for that letter of medical necessity. We're also going to look for any office notes. So history and physical with your provider, any treatment notes if it's a treatment that's been ongoing. If it's a treatment that's just starting, we're going to look for a treatment plan. So what are we going to start with, and what is our intended outcome for that treatment? And that's what we're going to look for, and it will be submitted into Cigna, and then it goes through the same review process.
Medical necessity, we should also say that includes treatment notes and a treatment plan, so it's
Yep. And I think, and correct me if I'm wrong, was there an FAQ document? I think if you have the frequently asked questions document that's bulleted out, in there so you have it as a takeaway as well. But just a reminder that that is for out-of-network providers. In-network, it's going to happen without you knowing about it. Thank you. It's number 8 on the FAQ. Oh, okay. Yeah, I understand that was also emailed. So you should have that in your email as well if you're not here to get a paper copy of it.
We talked about things that were specifically excluded from pre-certification. You mentioned mammography. I'm looking at a whole list of stuff that came in the literature. At the bottom, there's one that really concerns me. Unlisted outpatient procedures. Certainly that is very broad and very all-encompassing of any procedure that you could have as an outpatient. Is there a master list, and how can we as an informed consumer make decisions on our healthcare with such a vague statement?
Excellent question. So an unlisted outpatient procedure is a procedure for which there is no CPT code. If you've ever seen a CPT or a procedural technology book, it's 2 volumes. It's about this big, followed by one that's about this big. So the unlisted procedures are very few and far between. But if you're looking to see if something has a procedure code, you can Google. If you're, let's say I'm going to just pull something out of my head. I'm going to have a cortisone injection in my foot. And I go out onto Google, I type in CPT code, cortisone injection in foot. If I get a result, it's not an unlisted procedure. We've got a procedure code for it.
How do we know which procedure codes require pre-authorization, which ones do not?
Another very, very good question. So if you were to go out to Cigna.com, if you use the link for Cigna for Healthcare Professionals, there is a link in there for coverage policies. You can go out and look in the coverage policies, but there is also a comprehensive list of what does and what does not require pre-cert. I would suggest not printing it out because it's a couple of 100 pages. But the best way for you to find out if something does or does not require a pre-cert is to ask your doctor for the CPT code they're going to use to bill and call customer service. They can look it up for you.
I'm just going to keep rolling here with this train. I see that obviously we do not have to have referrals to see a specialist. My other concern is that if I go to see a specialist, hypothetically, whatever procedure my specialist wants to do to me, if that procedure requires pre-authorization, that's going to require me to miss more time off work, and it's also going to require an additional office visit to have that outpatient procedure completed. Is there a mechanism in place to prevent those repetitive visits for the same ailment?
So most of the procedures that we talk about when we say that something requires a pre-cert are not things that can be done in the office on the same day as your office visit. So I'm going to go back to my cortisone injection in the foot example. So if I go to a podiatrist because I have pain in my foot and I'm there for my first exam and they say we can do a cortisone injection for you, do you want to do that? Do you want to go down that route, yes or no? If I say yes, I want to do that, they're going to schedule me to come in for another appointment to have that cortisone injection done. In that time frame is when they're going to call to verify the benefit and find out, oh, I see some head shaking. No, they're going to do it at the same time. Okay. Woo. Okay. So, in that case, it's something that they would at that time while you're in the office call and see if it requires a pre-cert.
And while we're on the subject, what is the timeline? I see the definitions here, the reference to urgent, emergency, future, and current. Can you tell me specifically the difference between emergency and urgent? As I understand, emergency does not require pre-authorization, but I have a follow-up question on that in a moment.
Okay, so emergency is if you're in the emergency room, if you've gone to the emergency room for a service.
And then what constitutes urgent?
We use the prudent layperson definition of what is an emergency. So if you're in a situation that you think is emergent and you need to go to the emergency room or to an urgent care center, then we do consider that an emergency.
And follow up to that, I am understanding that there is a provision through the Affordable Care Act that specifically says that insurance companies can't require pre-authorization for out-of-network treatment. My question as it pertains to Washington County Public Schools is, do we have a mechanism in our agreement with Cigna to keep, should ACA go away, do we have a mechanism that we keep that privilege that we do not have to have pre-authorization for emergency care?
Great question, and one that I'm going to punt to my partners over here. Did you hear the question, Andrew, as far as ACA is concerned?
So I guess what I'm asking, long story short, is our exclusion for emergency care dependent on ACA or independent of ACA? Okay.
Yep.
You're talking about two different things now. So emergency room, that situation, like the ACA stipulation that you're talking about, has never applied to any plans that we've done for medical management since it rolled out in 2010. So it's on our entire fully insured book of business, and that includes all other carriers that do this same medical management. So I'm not sure about that provision that you're specifically speaking to. But the emergency room piece, that's a separate dialogue in regards to how we do pre-certification. So we got a question through one of your emails around if you were incapacitated, you're unconscious, how does the pre-certification process work? On the FAQs, we answered this one as well. You'll be treated, there will be no certification required. The services will be rendered, whether you're in or out of network in that instance.
Even if the provision in the ACA goes away, we will still have the privilege to be treated out of network or in network.
That's happening today. So
okay, but if ACA goes away,
before ACA, we treated emergency room the same way before. So it's been static across that ACA provision.
I wasn't sure if we were dependent
so
on that
I think that
legislation or not.
and that's a great question because sometimes there's confusion around emergency room services because some of our competitors will on the back end review emergency services and say that really wasn't an emergency. So I'll give you an example that really was a thorn in some people's sides in previous years when I've seen this from other carriers. You had chest pains that turns out to be heartburn. You called an ambulance, and they say that wasn't really truly an emergency. That's why we use the prudent layperson's definition to say you thought you were having a heart attack, so you went to the hospital. We're not going to go on the back end and say that was truly just a PCP visit. You need to pay for the ambulance and so on and so forth. That was before ACA, and that'll be after ACA. We believe in that prudent layperson definition.
Excellent. So one more. I'm just going to keep rolling. You give me the mic, and I'm just going to keep going. So
I think these are good questions for everybody to hear, so I think that's valuable.
So am I correct in my understanding that the primary reason that we're instituting this is for cost savings? It's kind of yes or no, just so I'm upfront about.
So it's to help manage the plan costs because I think that if you think about from an aggregate level of the health insurance industry, there's a lot of defensive medicine. So just ensuring, to Sarah's leadoff point there, that you're getting the right care from the right provider at the right time. So it's not about denying services, it's about matching up your diagnosis to what the doctor is prescribing to you. So if you walk in and say, I'm feeling X, Y, and Z, they say, well, you know what, let's run a CT, a PET scan, an MRI, and an X-ray, and we'll figure it out. That's driving costs to the plan that reflects back to you on your premiums. So if we're managing that to say, my finger needs to be X-rayed as opposed to let's get an MRI and figure out what all these different things are, we've eliminated thousands of dollars of costs. That's cost savings, to your point, but for a purpose, though, not to eliminate services, just to make sure services are being rendered properly.
If I can just kind of expound on that and give you an example that might hit home as a customer, as somebody who has treatment. I worked with a customer a couple years ago who was being treated for Lyme disease. And the industry standard, the accepted medical procedure right now for treatment of Lyme disease is a 28-day course of intravenous antibiotics. Okay, so that was what is in place. The provider that this customer was seeing was actually prescribing a lot of really unnecessary and really invasive procedures for this customer to the tune of intravenous oregano oil therapy sessions, to situations where this person was having coffee enemas, things that, you know, we would just normally think, wow, you know, you really, that's what they prescribed for you. And this person was so desperate to believe that these treatments were going to help her outside of the IV therapy, the antibiotic IV therapy, which she had not had at that point, that she put about $500,000 on her credit cards to be able to pay for it. So, you know, it's a situation where if we were able to intervene there through that pre-cert process, if, you know, this provider was calling in and saying, I want to do oregano oil IV therapy with somebody, we'd say, okay, wait a minute. Let's take a back up here. Let's talk about, you know, why you're doing this and what's going to happen here. So, you know, to Andrew's point, the plan spend on all of those treatments was over $1 million, and to that person, they're now sitting on, you know, $500,000 of credit card debts for services that really have not helped her get better. You know, to add insult to injury on that one, she started taking her whole family to this provider as well. So, you know, it's a situation that happens in everyday life, and I completely understand your concern and the questions that you're asking, and I think they're great questions. But hopefully that will kind of help put that in perspective as well from a real life example.
just want to add on one more thing around the cost savings commentary that they're providing there. I mean, ultimately, some of this will drive cost savings brass tacks. It most certainly will. But the mechanism around that, let me give you another example about how it drives savings. Let's just say I was diagnosed with end-stage renal failure and I have to go get dialysis. And I'm new to the area, and I have no idea. I'm not using any resources through Cigna yet to identify an in-network provider. And you go out of network for dialysis is about 4 times more expensive than it is in network. So that pre-authorization process, as part of that process, when you call us, we'll say, hey, Andrew, do you know that there's an in-network facility around the corner from your house? Your copay will be less, your out-of-pocket expenses will be less, your deductible will be less. You stay in network. The plan saves money because they were directed towards the same level of care in a facility, but they were in-network facility. That drives savings as well. So that's part of this process too, is to engage you as the member to say, do you know what's available to you? Do you know how your benefits work for this certain procedure that you're having done? We help you schedule appointments. We provide you backup support when you get discharged from the hospital. It's not just about denials, and I want to make sure that's very clear. This is around helping you manage your care, getting you engaged with a case manager, seeing you back to health. That's ultimately the idea here. It's not about saying no. So I just want to make sure that's clear. So savings are derived from many different ways, and one of them is by you were ill and we get you back to healthy sooner and you have no readmissions or no other issues on the back end.
And my concern with asking you about your compensation structure is, are you on a commission scale where the more you deny or save, the more money you make? Because I could see that being a slippery slope where making money could be at odds with our health.
So I'm going to have to do 2 parts here because I need to be mindful of Tricia and her team with your funding arrangement. All we are is your minister of claims in a network. So this is your dollars that are being spent on these services.
But the administration of, I understand that we are self-insured, but my question was the compensation structure for administration of the managed care program.
So obviously we're not for free, we're a for-profit company, but as in regards to us gearing people towards facilities, we're driving discounts, which again is our fiscal responsibility to you as our ASO client. So the discounts that we realize in those deals from the actual procedures are discounts that come back to your funds. We have arrangements, obviously, and our administrative fee covers our compensation, but the actual, which is probably 15 cents on the dollar that you spend with us, our administration piece is very small to the 85 cents you spend per dollar on services. So it's not really me saying, let's go to Dr. Belmere because I get a bigger check from that perspective. And then to go even further, there's a scenario where there's no in-network providers within a certain distance. We're going to cover that closest provider to you because that's a hardship situation to make sure you're not driving 80 miles in that scenario.
Okay. Great questions, though. Thank you for that.
My question has to do with outpatient services and specifically medical injectables. With medical injectables, oftentimes you have to go every so many weeks, for instance, maybe 6 weeks or 8 weeks.
Mm-hmm.
Do you have to get pre-certification every single time you go, even if that medical injectable is your maintenance medicine, like somebody's daily blood pressure medicine? Do you have to get pre-certification every single time?
So it's kind of 2 separate things. When you talk about, your daily blood pressure medication that you're picking up from the pharmacy and you're taking, that really has nothing to do with what's happening from the outpatient perspective.
I'm just using an example. Like
Yep.
an injectable is a maintenance medicine for somebody.
Yep.
So do you have to get that pre-certification every 6 weeks, 8 weeks?
No. So the short answer to that is no.
Okay.
The long answer to that is it's going to depend on what the length or course of that treatment plan is. So if you're prescribed this medical injectable, your doctor wants you to use it for 6 months. When they make that request, they're going to ask for the 6 months. And when we look at it against the coverage policies that we have in place, we're going to approve for the entire length of treatment.
What if it's like an infusion that's indefinite? That's your medicine, and you have no idea how long you're going to be on it as long as it's working for you.
Right. So again, it's what the doctor is prescribing as your treatment plan. So a lot of times when we see these kind of these infusions that come in, right off the top of my head, I think Crohn's disease as one of them. A lot of people suffering from Crohn's disease, a lot of infusible medications that are happening with that. It's really dependent upon each person's individual case. Most doctors are not going to say this is indefinite. We're just going to do this forever until, the end of time or until something better comes up. They're going to say, we're going to look at how this works for 6 months. Once that 6 months is over, if it's working for you and it's great and it's really helping and benefiting you, they're going to request an extension of the authorization. And it's going to happen really behind the scenes. It's something that we don't want you as the customer to have to see. So, again, it depends on what the medication is, what it's treating, but it is going to be for the course of the treatment plan. You're welcome. Yeah, absolutely. So I don't know if everybody heard that, but the question was, can I expand that into physical therapy or behavioral health treatments? Again, when a provider is requesting those authorizations, they're looking for a specific time frame for care. Physical therapy is actually a great example. If anybody in the room has ever had physical therapy, sometimes you go and you go to 5 visits and you feel great and you're like, yeah, I don't need this anymore. And sometimes you go and you have to go for 6 months before you start to feel better. Throughout that process of authorization with physical therapy, the doctor is going to ask for a certain number of visits, at which point, once those are over, they're going to ask to reevaluate you. So they're going to see, how far you've come, what is the prognosis, what are we looking to achieve in the next, many number of visits. Typically, you're going to see an approval for anywhere from 5 to 8 visits to start out, and then a reevaluation. The doctor's going to say, okay, I think we need this many more to continue with the care. They're going to request those additional days. And the same is true with behavioral health. If there's an outpatient behavioral health treatment that's going on, I want to stress here that, when we're talking about behavioral health especially, your individual therapy, your group therapy, office visits, things like that, those do not require pre-cert. So if you're just going, for your normal visit, whatever the case may be, pre-cert isn't even on the table there. When you're talking about mental health, we're talking about things like intensive outpatient. Is anybody familiar with what intensive outpatient is? It's a level of treatment where you are actually going in every single day to have some sort of treatment done. You're going to a facility, but you go home to sleep at night. That's the best way to explain what intensive outpatient is. It's for a certain number of hours during the day, but you go home at night to sleep and then you come back to the program. So those are the kinds of behavioral health outpatient visits that we're going to look to have pre-cert for. Outside of that, there's not going to be a pre-cert for them. You're welcome. Oh, sorry.
Back to you.
Back to the outpatient services that were brought up, and the first one says certain outpatient surgical procedures. Does that also the ones that might have no CPT code, or can you give an example? Because that's pretty broad.
It is pretty broad. Certain outpatient surgical procedures, knee replacement would be one that that could potentially require pre-cert. Lumbar fusion. Is anybody familiar with what lumbar fusion is? Yeah, you have lots of questions too, so I can imagine what those are going to be about. But those are the kinds of outpatient procedures that we're looking at that, you're going to go to a hospital or an outpatient surgical facility to have that done. Those are the kinds of outpatient procedures that are going to be looked at for pre-cert.
Okay, and I just want to go back to this number 8 about what you need for pre-cert. Under 8A, it says you can request a letter of medical necessity, but you made it sound like we must request that.
If you're seeing an out-of-network provider.
Okay, you might want to rephrase that, because it says you can. To a lot of people, that might not seem mandatory.
Well, and I hesitate to be absolute and say you must, because ultimately the goal is that when you call in to find out if something requires a pre-cert for an out-of-network provider, our customer service teams are trained to really help you as much as humanly possible to get what you need to get that authorization in place. So, the scenario should go something like this. I'm having this surgical procedure. Here's the CPT code. Does it require a pre-cert? Yes, it does. Is my doctor in or out of network? Your doctor's out of network. Okay, what do I need to do next? And at that point, customer service should be saying to you, these are the things that you're going to need to get this authorization started. Who's your doctor, and is it okay if we call them to let them know what you need? Ideally, that's what we'd like to see happen when you call customer service. If that doesn't happen, or you get in a situation where we call that provider on your behalf and they say, I'm not dealing with you. We're not in network with you. We have nothing to do with you. I'm not sending this to you directly. That's the point where you're going to have to step in as the consumer and say, okay, this is what I need in order to get this ball rolling.
Frustrating when you're needing medical attention.
It absolutely is, and I agree with you on that. You know, the best thing that I can say to you in that situation is use in-network providers as much as you possibly can. I know. I know.
We don't have an overabundance of doctors like they do 100 miles down the road.
Yep. And you know, I understand where you're coming from because I'm actually from northeastern Pennsylvania, and I'm, you know, kind of in the middle of nowhere as well. If anybody's ever watched The Office, I'm in Scranton. So, you know, while we might seem like a thriving metropolis, we're not. You know, so I can understand and I can appreciate where you're coming from on that. But, you know, if there's anything that you walk away from today with, it's knowing that our intent, the intent of our customer service teams, the intent of my team, of Andrew's team, of Jesse's team, of Chris's team, is to really help you through this process if you need help with it. So, you know, if you do get in that situation, call customer service. And, you know, we're going to do everything that we can to get what you need to get that pre-cert.
And as part of the review, when we were coming on as the carrier, we did an analysis, and that was vetted through the RFP process and the procurement process to make sure we had adequacy and from a network perspective. But you still have out-of-network benefits. That's obviously your choice to go out-of-network. That's everybody's choice in this room. You're obviously going to be exposed to more cost, and under this model, there's going to be a little bit of responsibility in regards to pre-certification. Now, ideally, when you're planning these services, because I think one of the takeaways that we heard from one of the earlier answers was, these are not necessarily going to be always things that you come in that day and they're going to happen that afternoon. Now, I know that there's instances where they do, but a lot of these are planned services. So if I'm getting my knee replacement, I got to check that I blew up my knee. My surgery is X amount of days. I love this doctor. He did my friend's knee. He's out of network. I want to go see him. So then you're armed with the information to go to prepare to facilitate that conversation on the front end. So again, you're choosing to go out of network. So part of that onus is on you to get that paperwork together on the front end. So again, I'm from West Virginia. I'm from Morgantown. So I mean, I get driving, I get driving other places. My dad worked in Fairmont. He would drive to Morgantown if he actually drove to Morgantown from Fairmont with a heart attack because he didn't want to go to Fairmont General. I understand the scenario of picking the right facility for you, but at the same time, though, if you're going to go out of network, that's a choice that you're making. And when I'm trying to deal with these providers, I don't have any leverage in a conversation with a network provider. So when you go to an internet provider and they're screwing around with paperwork, we can call them and say, do you want to continue to be in our network? Yes or no. And if the answer is no, then we remove them. They lose revenue. So that's why they're incentivized to listen to my phone calls. So when you go out of network, I don't have any control over that conversation. That's why they're out of network. That was their choice.
And I agree with that. I was just looking at this number 8. If my doctor's out of network, what do I need? So what you need to do is call Cigna.
Yes.
I mean, that would be nice to have that outlined. Call Cigna and give them this. That's all I'm asking.
We're trying to. It's hard to deal with every single provider, to Sarah's point, from an absolute perspective, because some providers we work with frequently from an out-of-network perspective, they like talking to us. We deal with them. We just couldn't come to a place of a contract negotiation. There are other providers that just refuse to speak to us. So us calling them and we call them back and what have you, that's not going to get us anywhere. So to put that information on there, and then you get in that situation and you really need something, and we haven't been able to get a hold of them, that really truly creates the delay that we're worried about right now. Trying to cover all bases here, it's a tough conversation to have when you go out of network because I can't speak to every single provider out of network.
Okay, I have a few.
If I come over here, will they still be able to see me? Will it follow me? Okay.
I have a few. First, let's follow up on Andrew and the out-of-network. If an out-of-network doctor chooses to assist the participant and help with the pre-auth, can the out-of-network doctor do that?
Can they help?
Yes. So if the doctor says, hey, I'm going to call Cigna and do this pre-auth,
Absolutely.
we're okay doing that.
Absolutely.
If we say to the doctor, hey, you're out-of-network, Cigna says I need a pre-auth, the doctor can,
Absolutely.
or his or her staff, can assist in that process. They are allowed to do that.
Yeah, it would be most helpful if they did.
Okay. All right. A follow-up on the injectable and other related. If a service is currently covered, this is a question. In my role, I've been fielding a lot of questions over the last few days. So if there's a procedure, an injection, etc., currently covered, will any of our participants, whether they be our newborns through our 90-year-old retirees, will they see a change if it's currently in place and currently covered
So let me make sure that I understand. So if somebody is actively in treatment today
today?
and they are having, you know, their IV therapy or whatever the case may be, what happens to them on 2-1 is your question. So it's an excellent question, and I'm glad that you asked it, because once 2-1 happens, that authorization process is going to come into play for them. So, you know, in the essence of being proactive, that's something that, you know, that conversation should happen between that person and their doctor to say, hey, there was a change that was made on 2-1. Can you give me the CPT code so I can call and find out if this needs a pre-cert, or can you do that for me to find out if it needs a pre-cert? Because honestly, your doctor's not going to know. They're not going to know that this change has been made unless you tell them.
Okay, so that might be something we as a school system can kind of push out. Hey, by the way, if you're in the middle of a long-term therapy, make sure your physician sees this. You know, whether we can give them a script, something.
And there will be new ID cards coming out with this language on there, and you're going to need to take your ID card to your provider because it will have different language on there around this pre-certification. So that's something to note as well, and those should be coming out for 2-1. Getting a glass of water. So that's important to note. And then again, proactivity is the best. We're doing this as a mid-year change because that was what was voted upon by the board. I mean, we've had lots of discussions, as you know. So again, the more that you can communicate with your doctor, even if they are in network, to say, hey, this is coming, doc, can you start making the phone call right now so we can get this so there's no breaking coverage? Because, I mean, I'm not going to sit here and say that it's going to be 100%. There might be some snafus that we run into. Just this reality. But we need to make sure the providers know. And I think this is also a good time to note, a lot of times when I do see denials, this is something that I've talked to a lot of the board here, is that when we see a denial, it's usually because we don't have all the correct paperwork. It's not because we're denying a service. So that's something that, you know, hey, doc, you know, you didn't send in all this information. And once we get it, we usually, it's streamlined and approved. And to your point about if you have something that's covered today, benefits are not changing. That's a very important note. Benefits are not changing. The review to get to certain benefits, these outpatient benefits, is what's changing. So the limits are not changing. The covered services are not changing. It's just the authorization to get to those services. So I wanted to clarify that for everybody.
All right, next on the list, NICU services. We know we talk emergency room. How is this going to impact NICU services? We have a lot of young families.
So NICU services, maternity services, as you know them today, that is already part of the inpatient pre-cert process. So how does that change as of 2-1? It doesn't. That's already been in place.
Perfect.
Actually, you know, let me just add on to that a little bit, because, you know, as part of the package that is being put in place, something that is really good about it that happens when there's maternity or there's NICU services like that is the increased engagement of a case manager. So, you know, a case manager would already be assigned if there was somebody that was in high-risk maternity, if there was a high-risk birth, if there was a NICU birth. So what's going to happen as part of this new program that's starting is not only is there access to a case manager, but then there's also increased access to social workers, to social services within the area. So there's an increased level of engagement there as well for services, not only while that person and while that baby are in the hospital, but when they go home too. So if, you know, if there's increased, you know, feeding support or something like that that's needed, you know, with the NICU baby training, education, things like that, we have home health care, you know, we have these in place now where we can have further engagement with the case manager, with social work, to be able to really support that mom and dad when they come home and baby.
All right, next question has to do with prescriptions, prescription medications, step therapies. Will participants, again, regardless of their age, as long as they're currently in the program, participants with our insurance, how are they going to see any, or will they see changes regarding their medications, how medications are doled out? Will there be a change? That's been one that I fielded a couple times.
So from a pharmacy, normal pharmacy like CVS, home delivery, the current edits that are in place today will remain today. The authorizations that are required for those will be the same. If we're talking about medical specialty infusions and things like that happen in the doctor's office, there will be a review process put on those now. So that's a difference. And yeah, I mean, we've addressed with Tricia and her team some very specific situations that we're going to take care of on the front end.
All right, thank you. Last couple. One person was really concerned, and she shared her concerns, and I'm going to paraphrase from some very lengthy emails, but in short, excuse me. Her concern is we're going down kind of the old HMO route. We're going down the road of this is going to be forced care. This is going to be managed care. You're going to be penalized because you drink too much, you smoke too much, you don't go to the doctor enough, you're too skinny, you're too fat. How do you respond to any participant who's going, whoa, Cigna is going to manage my care and determine how often I go to the doctor and the care that I get? And if you could put that in a nutshell.
So I'm gonna address it from the customer perspective, and then I'm gonna give it to Andrew to address, from the account level. So as far as a pre-certification is concerned, if you're seeing an in-network doctor, and that doctor fails to get your pre-certification, and then goes ahead with a service anyway, so if they either don't call or if it's not medically necessary and they get a denial, and they provide that service anyway, the customer is held harmless. Okay, so if that happens, that's on a case-by-case basis again, that's something that we would look at individually. But if you are at an in-network doctor and they either get a denial or they don't get the authorization at all, as a customer, you are not going to be penalized. You're not going to be punished or billed for that. I say that with one caveat, and this is something where you really have to pay attention when you're at the doctor's office or when you're at a facility having a service like this done. Who has ever had a service done where you are in an office and they give you a stack of papers to sign and you sign them and you don't read what they say? I do. I'm just as guilty as everybody else. So if you're having a procedure done and you are not 100% certain, you do not have the letter in your hand that says my authorization has been approved, read what they're giving you to sign. Because something that doctors will do is they will slide you a paper that says, if your insurance denies this service, you are responsible. And once you put pen to paper and sign that, they can bill you for it. Okay? So it's really, the onus is on you there as the customer. Make sure that you're looking at what they're giving you to sign. Ask your questions. I know I'm the same way. I've got 2 small kids. When I go to the doctor's office sometimes if they want to do a procedure, I'm so worked up about what's happening at that time. I don't know what I'm signing. I could have signed the Declaration of Independence when my son had his adenoids out. I don't know what I signed. I signed it because I knew that my kid needed care. So it's something that is really important and that I really try to stress with people. Just make sure that you're aware of what you're signing as you're signing things in the doctor's office. So I don't know if that adequately answers your question or if you want.
A little bit more probably needed on a higher level. I mean, my view on truly managed care would be the bottleneck, where you must, and I grew up in an HMO plan, so I break my thumb playing football. I have to go see my PCP before I can go see the orthopedic. I have to get the approvals, and if I want to come back, I have to go back and set another appointment to go back to the orthopedic for my next visit. I can only see this orthopedic because that's what the one that they're aligned to. We're not talking about that sort of model. And I don't think the industry is going to that sort of model either. In regards to the policing of your care, I think one of the parts, we try to hit on a few things because we're trying to address your all's questions and concerns and fears, but rolling this out also adds a lot of resources for these individuals as well to help them manage their care, like we mentioned for the pregnancy piece there, the social work, the early identification, the case management, what have you. So it's about you being put on the right path from that situation beginning until you being better, or managing your chronic condition along the way as well. If you have a flare-up and you need to take something for a short period of time that requires authorization, and getting you back to just managing your condition. So not about directing your care. And the offer, I mean, it's in the FAQs as well, if there is a denial that comes through, and I'm a part of this situation when they get escalated, if this is something that comes across my desk, we schedule a peer-to-peer review. It's not just a random doctor that works for Cigna. If it's an oncology situation, it's a cancer denial, we're going to have our oncologist get on the phone with the doctor, and they're going to have a peer-to-peer conversation to say, this is what I'm basing my request upon. This is what you're saying in your notes here. I'm trying to follow what your game plan is here for your course of action. So I've seen things overturned because I see what you're saying and where your end game is, Doc. Let's get on that same path. We'll get that approval, put it in the system for you. We'll move forward. Like those conversations do happen. So it's not about telling your doctor that he or she is wrong. We're just trying to understand from the diagnosis, which all doctors work from the same American Medical Association normal guidelines. They all read the same journals. They all see the same studies. So we're saying based on these studies, the efficacy we see, the results that we see, the medicines that are out there, the procedures that are out there, this is the path that they should be on. You're taking them on a different path. We just want to know why. Or you haven't had this test done in a year and you're asking for the next test beyond there. The usual protocol is to have this test first. Why is that test not happening right now? Those are the kind of questions that we're asking. Those were denials come up. And it's also thinking about maybe PT might be the answer for you as opposed to having a major surgery. So the example that she gave about doing different procedures. So getting you on a different path. And again, you as the patient has rights too, obviously. And you can take this to a third level of appeal. There's many options, but it's not about coming in and saying, do you smoke, do you drink, are you unhealthy, whatever. It's about treating you, getting you resources, finding the right path for you to be on so you can manage your care the best. Like that's why I think that the intent is from our perspective. We don't want to go down the managed care path. I think that created a lot of problems that we had to dig out from a long time ago. I think that what you're going to see from all carriers across the board is medical management products like the ones we're putting in place today. I think medical costs are out of control. I think providers, to use that gentleman's example earlier, I think they get a lot of money in the back end for doing certain kind of procedures. So I think that's part of the equation as well. And why are they doing them? Because they get a lot of money when they do them. What's the reasoning behind it from a diagnosis perspective? They don't really have one. So that's where we're trying to prevent and save that money there. So that's another cost savings by saying, what was the purpose of this decision here? This is not going to help the individual because we're thinking about every individual on the plan, every belly button, making sure they're all right. We're managing the care and supporting them with everything we can from our perspective. And WCPS bought a rich plan. So this is part of adding to that plan to make sure it is as rich as it possibly can be to support the members. Is that a better answer for you?
Thank you.
I saw a hand back here. You? Yeah.
I have a question. My wife currently has a procedure scheduled for middle of February to have a hip replacement. So before that can be done, we have to make sure that person is an in-service provider.
So an in-network provider. You're going to want to make sure that the surgeon that's doing it is in-network, and that ideally the facility where it's being done, so whether it's a hospital or an outpatient surgical center, you're going to want to make sure that that's in-network too.
And what about the physician himself has certain requirements. He wants certain tests done before she goes in. It's an inpatient. It'll be done in a hospital.
Oh, it's going to be done inpatient?
It's going to be done in a hospital, yes.
Okay, so if it's, and she's going to stay overnight, I'm assuming?
I believe so, yes.
Okay, so if it's an inpatient procedure and it's the middle of February, I think that, it's probably safe to assume at this point they've already started the inpatient authorization. But if you are not sure, you can absolutely ask the doctor's office if they've started that process. You can absolutely call Cigna and say, this is, my wife's having this done. Can you confirm for me that this doctor is in network, the hospital where she's having it done in network, and have they started the authorization?
Okay.
But in your situation, I would probably ask the doctor first.
Okay, because I know we're going down there for a seminar next week, I believe it is.
Okay.
Thank you.
You're welcome. Okay, so pre-admission testing. We'll start. Yep. Okay, so I'll start with anesthesiologists, radiologists, and pathologists. We'll go there first. So those are kind of, is that okay? Yeah, okay. So we'll go there first because those are the folks that, you usually don't see. They might walk in and say, okay, I'm your anesthesiologist. They have a mask on. You don't know who they are. They don't come back ever again. You don't have any way of knowing whether or not that doctor is in or out of network. So what will happen when you're having an inpatient procedure is those providers actually get tied to the in-network facility. So any pre-cert that's happening for an inpatient procedure, that's all getting tied into the same authorization. The same is true for an outpatient surgery. So all of those other professionals that are going to be involved in the surgery, anesthesiology, radiology, if you're having some kind of biopsy, the pathologist that's going to read that, those are all tied to the same authorization. So each person doesn't have to get an authorization. Pre-service MRI or?
Let's stay there for a second. So if you get a bill from an anesthesiologist, but you were at an in-network facility, disregard that bill until you see your EOB, because they bill first, and then when we tie them back, it's considered as the in-network benefit. So, and I want to caution this, and I talk to all clients about this, if you pay that provider and then you're owed money back, I cannot force them to do anything quickly. I can tell them that they owe you the money, but it's not a check coming from Cigna, it's a check coming from Dr. So-and-so. That's why I say wait till you get your explanation of benefits. And if you're going in-network, all those people that come into the room will be tied to that in-network procedure. And so if they send you separate bills, wait till you get your explanation of benefits. That means that we've already paid them, and that's basically your receipt of our payment to them. Then you make your payment to the facility. If you pay the facility or the anesthesiologist before that, I cannot force them. Then it's at their leisure to pay you back. So I just want to make sure we're all on the same page there. I can only push so hard, and it's about their billing department at that point. It's not about Cigna cutting you a check, because it's their responsibility to pay you back.
Be clear, doctors in network.
And then you're good. Yep. So your pre-cert is going to cover all of that. It's a good question. They're all good questions.
Yes, I had a question. If Medicare is your primary and Cigna is your second or your supplemental, does all this still apply?
No. So if you have Medicare primary, Medicare is going to handle your authorization.
Sorry.
I. So there you go. They'll get it for you in writing. But yes, if your Medicare is your primary, Medicare handles the authorization, and then we honor that as your secondary.
Because it will go to them first.
Mm-hmm.
One other question. If you see someone and you're not sure, like I do go out of town to see someone, how do you know if the person's in network or not?
So you can call customer service. That's probably your first stop. If you are cell phone savvy and you have a smartphone, you can always check on the mobile app. It's on there for you on the go. You can always look on MyCigna as well if you're registered for MyCigna. But if you're on the way to the doctor and you think, oh my gosh, I never checked, and I don't want to be unsafe and check on my phone while I'm driving, give customer service a call and they'll be able to tell you.
But if that member is Medicare primary and Cigna is supplemental, then that's a moot point, right?
In network?
To find out if it's in network.
It's a moot point if they're Medicare primary.
Other questions? Yeah.
I just wanted to revisit the urgent care versus emergency care. Could you give me an example of a situation that would be an urgent care situation, an urgent situation, as opposed to an emergency? You gave me a great definition of an emergency situation, the layperson, but you didn't really touch on what it meant to be urgent. And I was going back to the example of your cortisone injection. Certainly no one wants to lay in pain and wait for 10 days if that is a future perspective, and even 3 days is going to cause me additional time off work and additional pain.
So I'm going to go back to the prudent layperson definition of what is an emergency, and that applies to urgent care as well. So in really, really general terms, if there's something that you feel is emergent and you need to go to the emergency room for it, you go to the emergency room and get it done. If you feel that it is emergent, but it's maybe not something that I have to go and sit in the ER for, but I'm going to go down, I'm going to go down the street to the urgent care center. Both of those really work off of that prudent layperson definition of what is an emergency.
Okay, so those are emergencies.
If you think it's an emergency
Right,
and
okay,
you're going to
gotcha.
go use one of those, if you want an example of what we consider.
So I think that what you're trying to get at is if like you're at an outpatient facility and you're planning and you go in for like a visit
Yes.
and trying to understand and getting that cortisone shot that same day, that's going to be different than if you go to the emergency room or the urgent care.
So if we want to circumvent the system, we'll go to the emergency room.
I wouldn't recommend it necessarily, but if you're in that much pain and that's an emergent situation, then you go get it taken care of. I would not say that it's, and this is just my personal definition, if it's that emergent, I'm not making a phone call and scheduling an appointment a week later to get to see my outpatient doctor. So that's where the differential comes in regards to the location of where you're asking for the review to be done.
And I guess what is an example of emergency does not require pre-auth. We've established that. But when would this urgent, this 3 days from request, apply?
So in a situation like that, and I don't want to get too specific into things because again, it's going to depend on each individual person, each individual doctor. Cancer treatment. You know, if I'm having a cancer treatment and they've decided that they want to try, you know, a different kind of procedure on me outside of what I've standardly been using and it needs a pre-cert, then they would review that, and and it needs to happen in a couple days. They would review that urgently.
Okay.
So, you know, it's really hard to tack down perfect examples and all the definitions because every person is different, every situation is different.
Well, now, Sarah, keep me honest here. I would think about it like if there's a car accident that's emergent, like serious acute situations, and if there's something that can be put off for a day or two and doesn't need to be scheduled in the middle of February, that would be more in my mind an urgent versus a prospective or a future. So if it can be done in the next couple of days, but it needs to be done in those couple of days, that would be to me more urgent. Emergency would be like, this needs to happen right now. Like you need to be in a room right now.
Okay, and to kind of spin off of that, it should with a situation arise that you go any of the categories for timeline, if there should be a denial issued and there is a review process, what's the timeline? Does that start over the 3 days? Is it 48 hours? Is it 10 days? I see this vision of somebody waiting on their cancer treatment. It's 3 days. It's an urgent situation. The doctor's reviewing facility or reviewing person at Cigna says, "Nah, we need more documentation. Did you run this test?" So we ping pong back and forth, and now we've exponentially added to the time that it takes to receive the care.
So the peer-to-peer process happens at the prescribing physicians based on their schedule. So if something is denied, the provider is going to get a letter faxed to them. So they're going to know, as soon as that denial is issued, they get a fax. It's in their office on their fax machine. If it's a situation like that where they say, we cannot wait to do this, they can call. As soon as that letter comes in, they can call and request the peer-to-peer review. I've seen situations for emergent care, something that can't wait the standard turnaround time. I've seen those peer-to-peers happen in the same day. I've seen situations where doctors say, I'm on vacation for the next week, so I'll call and schedule the peer-to-peer a week from now. But those peer-to-peer reviews do happen based on the doctor's schedule.
I think it's always important to note we're not trying to impede care. So I mean that's the main goal here.
Understood. I think that I don't think anybody wants to keep anybody from healthcare, but I think that what we see as clients is we see another roadblock to our care.
No.
And if we're being frank, doctors don't like Cigna. I'll put it out there. I had to beg my primary care physician to become Cigna, and they had not until Washington County Public Schools got Cigna. I'm sure I wasn't the only person, but our insistence, they did pick it up because we're 20,000 or so strong. So we see this as another roadblock to receiving the timely care that we need. And our concern is that ultimately what it's going to be is another roadblock, more time off work, more time away from our students. We want to be in the classrooms. We want to be there every day. We don't want to have to wait 3, 4, 5, 6, 10 days for a cortisone shot so we can walk around our classroom.
I want you in front of your kids as well. And I think the reason that we're still your partner of choice is because we emphasize, the member experience and trying to make sure you get the care that you need. I will say, though, from a provider perspective, I won't even get into probably the reasons, my guess is why the provider wasn't in our network before. But I will say, though, we're not the only carrier that does medical necessity review or pre-certs. When you look at other carriers that do this, when we say that, so she gave the example of when you ask them for this information and they know what we're talking about, it's because every carrier has their own medical management piece in place. So this is not a foreign thing that we're doing alone in the market. It's a lead offering for smaller businesses all across this area, all across the country. So, again, the idea is when you roll out a product like this, you have to have back-end support for the situations that you're talking about. We can't be laissez-faire and say, oh, we'll get to it when we'll get to it. We're going to try to push as hard as we can to get the information that we need so that you as the member never even know this conversation was even happening on the back end. Now, when denials do come up, and they will come up on occasion, you have avenues to reach out to Cigna to try to get them rectified as soon as possible, and it's always a priority for us that your care's not interrupted. I can promise you that. It's not about, oh, it's 5 o'clock, I punch the clock, I get out of here. There's a lot of commitment on our side from a customer service perspective and within this unit to make sure that we're reviewing this as timely as we can so that people don't have to reschedule appointments, stay out of work longer than they have to, miss care, disrupt their care. Because that ultimately, what's my ulterior motive in that? If somebody's dealing with cancer treatments and they miss that treatment, it's going to be a worse situation for me financially, for that person, for everybody involved. So I have incentive to make sure that person gets what they need as soon as possible in that scenario.
I just have a question because I don't remember. I signed up, and many people, this was a question, signed up for not the limited, not the standard, but the third plan. And I know you said this doesn't change our benefits or anything. Does this impact that plan at all? Because I don't think we needed pre-cert. Maybe we did. I don't know. Does this change?
It's across the board, all the plans.
But does it change this? Is it different than when I signed up for the plan back in July?
No, the benefits are not changing, just the authorization process for certain procedures.
So I didn't need that authorization when I signed up for this plan in July.
But the benefits are still exactly the same. So if you get the authorization, you can still access those benefits exactly to the same level.
Okay. All right.
Why now versus open enrollment time?
Did you want to address that one?
The program has been in discussions for several months, even before I came on board in May. So we had been interested in implementing it last July, and just the time was right. Everyone came to agreement. The board agreed and signed off on it. So better sooner than later to realize those cost savings now, rather than wait several more months. Anything else, David? Okay.
Will those cost savings be passed down?
We certainly hope so.
Anybody else? Anything from the stream, live stream? Yeah, and that's a really good question. It's another really exciting tool that will be at your disposal as well when it comes to advanced radiology. So, you know, your MRI, you're going to go get your MRI, and MRI will require a pre-cert to be done. So once you get that pre-certification for the MRI, someone will actually reach out to you and say, hey, did you know that the facility that you're going to charges 20% more for an MRI than the one that's 2 blocks in the other direction? Would you be interested in switching facilities and going to this one that will give you a cost savings? It's completely up to you. You don't have to say yes if you don't want to say yes. If you're comfortable with the place that you're going, then everything is done. You're set to go get your MRI and have your care. If you say yes, I would like to go to this other facility, then the representative will actually help you schedule that appointment at the different facility at your cost savings. So that's it's a little help for you there when it comes down.
A little bit of an administrative question. What kind of, I assume we're not the first people to ever do this through Cigna. What kind of plan savings is a program like this generating for this plan?
It's usually around 3% to medical and pharmacy claims. I'll caveat that it depends on your utilization prior to. So, I mean, there's a lot of things that go into that number. So I'll say approximately 3%, yeah.
What other questions do you have? How's the live stream? Quiet? Okay. Oh, sure.
Hi, I'm David Brandenburg, Executive Director of Finance here. And I just wanted to follow up on that question about the cost savings. Absolutely, the cost savings will come back to the employees and to the board who are paying the premiums. Because I want everyone to understand that what we are paying here, we're not paying an insurance company who's determining what rate to charge us. We are paying our own claims, and we are paying administrative fees for the network and for the administration of the claims. So if we are able to save 2% on claims, that'll mean, you know, that an increase in premium that would have been 5% would turn into 3%, for instance, or if it was 10%, it would be 8%, or, you know, so we look at the plan's actual results and project claims into the future when we determine what the rate should be for the next year. So actually, everything will come into that. Yes, and I think it's a very good point to say that this is more of an industry norm. This is something that we, you know, I thought we had this some years ago with Care First, and I don't know, but it is something that is industry norm, and Cigna is not the only one doing this, that you'd find this with no matter who the TPA would be.
Any other questions?
Did you say that they will be reviewed come February 1st if someone's on a specialty medication? What will happen with those?
So I was speaking more specific to the medical specialty the medical specialty RX that are out there. So if you're getting like an infusion, then those potentially could be need pre-authorization. Depends on what you're taking.
And my best suggestion there would be give customer service a call and say, you know, this is what I have in the pipeline. Does it require pre-cert?
And that's a great note, because we set up well, actually, I'll give Chris and Jesse the kudos. If you call into customer service now and you have like an example question, so you're saying I'm on X drug, come 2/1, well, I need authorization, they can help you answer that question and look through that now. Because we've updated our customer service center to say basically like a pre-enrollment line, because this is a new product rolling out. So you can kind of investigate whether this is going to be something that you need to start working on right now, or it's going to be fine come 2/1. So I hope everybody hears that on the stream as well. And that number's been posted. I mean, it's your customer service number, but that information's been posted in one of the emails that Tricia sent out previously. If you have like my child is dealing with this, or I have this, or my significant other has that, and I want to understand how the authorization process works, you can call right now and talk that through. So give examples, you know, what have you, so you can be prepared for 2/1 when this goes live. And to address your question, sir, about rolling out for 2/1, I do this a lot. I've been doing this for over a decade. Sometimes this being rolled out with open enrollment can be lost. Yeah, and I don't do it frequently mid-year, but I think having this dialogue puts a spotlight on it so that we don't have a lot of vitriol and anger if it was July 4th when people got a denial. So I think there is some value to doing it this way. So there's literally a spotlight on it, so you know what's coming, you can prepare for it. We can get over some of these humps, as opposed to open enrollment. There's a lot of information going around. You're maybe changing plans. You see lots of paperwork, and this is a one bullet point on there. Because I'm tasked with David and his team every year to bring out cost savings as just recommendations, and then we work with your consulting team as well. And this was one that we've been talking about literally since 7/1/16. So I mean, this has been a long time coming in regards to this being rolled out. But I think it was a good idea to do a communication plan around it so that you all were armed with the information before 2/1 to be prepared for it. That's why you see the whole team here today, sir. Yeah, so the new cards should be coming in the mail. I think they should be in the mail now, right? Yeah, so you should. Yeah, so I mean, I don't control the postal service, sadly, but they should be, because ID cards are always a pain point. But they should be coming to your homes very soon. So when you go to your doctor for your next visit, make sure you give them that new card, because it has the language on there that's very important. I would like to avoid doing new cards, but if we don't have this information on there, we would have a much bigger issue in regards to communications and denials. So just keep an eye out for those as well. Yes, ma'am.
Members can always get their copy of their card at mycigna.com.
Yes, to repeat that for everybody, you can go onto mycigna.com and print out an ID card, and you can also use your phone as your ID card as well, and have that updated information. That will go live on February the 1st. Yeah, and I carry a very small wallet, so I always use my phone as my ID card. And most doctors will let you, if they can't scan it on the printer there, you can email it to them right there on site.
Secure fax through the app.
Yeah,
even
secure fax.
Off-site.
Yeah, so there's a lot of ways that you can just leave it on your phone. So like I've left my house before sick and forgot my wallet, and I'm like, oh, this is gonna be terrible. But it's all on the phone in regards to getting that information out there. So a lot of ways to get the card out there if you need it. And again, I can't emphasize enough because we have our concierge customer service model for WCPS, Cigna One Guide. So when you call into customer service, we are trying to take the responsibility of you trying to figure a lot of this stuff out of your hands, because we speak this language. We talk to these providers all the time. So when you call in and say, hey, I'm having this done, we're going to say, hey, let me help you out. Let me make this phone call on your behalf. We'll call you back once we figure this all out for you and sort of the situation out. That includes denials. You were denied for this. Hey, Cigna, what's going on? We call Dr. Smith and say, hey, Dr. Smith, we didn't see this information. We get it for you. We call you back. We say your appointment's on. You have authorization. That's the idea behind this customer service model. It's not to leave you with homework. We don't want you trying to be doctors and Googling things and trying to figure it out. We're your resource, but it's always good to be knowledgeable, to Sarah's point. Ask your questions, be mindful, know what your providers are in network, watch the paperwork that you sign. There's a lot of moving parts when you go to get these major procedures, so you need just to be aware of what's happening when you go into the doctor's office. I appreciate everybody coming in and spending time.
Thank you all.
Yeah.
Great questions. Thank you.
One last thing. We are going to have a Cigna representative on site here every Tuesday starting in February. We'll see how long into the year we need to continue that. But Shakia will be here every Tuesday from 11 a.m. till 5 p.m. You can call her or come over from offsite. She'll be right out front in the lobby, one of those side rooms out there. So if you have concerns, more questions, something actually happened that you need to work through, even a claim to work through, please come and visit her or give her a call. Okay. Thank you again.